So, our topic today is all about genetics and family planning decisions in the world of NF. And we're very excited about this topic because we know it's a lot of importance to our community. And we're also releasing 3 new educational resources about these topics that I will, at the end of our session today, share a slide with a link to where you can find all of that information. So, having made all my announcements, I'm very excited to welcome Amanda Bergner. She is a genetic counselor, primarily working in the neurology department at Columbia University. She's also the director of the Columbia Genetic Counseling Graduate Program there. Amanda is a fabulous, dedicated advocate for this community. I've worked with her for over 10 years now. And she is just a real resource for all of us. So we're very happy to have her here today to kind of walk us through this big topic and what we need to be thinking about and how we need to be, talking to other people or maybe your children or thinking for yourself about these issues. So having said all of that, I am going to hand things over to Amanda and let you take it away.
Thanks, Kate. I appreciate it very much. Thank you for inviting me to be here with the community today, and welcome to everybody that is joining us. I'm going to go ahead and jump in so that we're sure to have time for questions and answers together during our time today, but definitely please feel free to use the Q&A throughout the time that I'm talking. At any point, you can enter a question there, and we will have some time at the end. So I'm going to start by just framing our time together today by saying that families come in all sorts of shapes, all sorts of sizes, all sorts of ways of being created. And what's important about family is that they are important to you. And so I'm going to be talking about a lot of different topics related to family today. And as we work our way through, please feel free to ask any questions. If you feel that there is a family relationship that we didn't cover directly, I'm more than happy to answer any questions. So when people are thinking about pregnancy and adding to a family, there certainly are a lot of different thoughts, a lot of different things to be working through. Some of them are listed here, some of the key ones that may surface. And when you're living with NF or schwannomatosis, there are a couple other things that people are often thinking about as well. The first may be symptoms of NF or schwannomatosis for themselves as they are experiencing a pregnancy, or their partner is experiencing a pregnancy, or a family member. And the second thing is about the inheritance of these conditions within the family. So often people are wondering about, will children of someone with NF or schwannomatosis also have the same condition? So we're going to be talking about those things in a little more depth today. I wanted to start here because I think sometimes when we think about families and having kids, it feels a little bit like maybe we can just talk about sugar and spice, but in fact, we're actually going to dig into genetics a little bit. And so that's definitely the case as we think about how NF and schwannomatosis families are thinking about pregnancy and family planning. So I just want to make a few notes as we get started. When I developed this talk, I thought it could be helpful for us to work through things chronologically from a lifespan perspective. So you'll see that that's how the talk is organized today. We're going to start from childhood and work our way through adulthood. Everything on a slide that's in orange italics is a question that I feel like has come to me through my clinical experience in NF. So I've been working in NF clinics at both Johns Hopkins and Columbia for probably the last 23 years or so. So I've received a lot of questions from individuals and family members. And so I wanted to bring some of those to you today. And anything that's in blue font is information that comes from a research study. So I'll also distinguish that as we go, but I just thought I would just let you know that as we get going. I also did just want to give people a little bit of priming around the fact that we're going to talk about some things today that for some people can feel of a sensitive nature, including sexuality and birth control, pregnancy and termination or abortion, and parenthood. So I did just want to let people know that that is included in the talk today. As well, this is going to be generalized information, so isn't specific to any one person or family, and it's important that taking information from today, you have follow-up conversations with your care team that can address things that are really specific to you and your family. I also want to just be sure everybody's familiar with how we'll use terminology today. So a few years ago, there was a new naming convention that was released in the setting of NF. So NF1 remained as NF1. NF2 is now called NF2-related schwannomatosis, and schwannomatosis became divided into several differently named conditions, really just related to the gene or the genetic change. But while we're talking today in this talk, I'm going to use, when I say NF, that means it applies to all of these conditions, NF1, NF2, and you'll see SWN for schwannomatosis. So let's jump in at childhood. One of the things that often comes up and people are asking a lot about is, when should I tell my child that they have NF? It's this idea of talking to children about NF. So parents often have questions about when it's appropriate, when is the best timing. Often it's a balance of, I don't want to scare my child. I don't want them to go onto the internet and see a bunch of scary pictures, but also I want them to have the knowledge and the information to be able to take care of themselves and understand maybe why we're visiting a lot of doctors or things along those lines. And so certainly communicating about genetic risk can be distressing for families. And this is true not just for NF or schwannomatosis, but for people with all sorts of inherited conditions. But what's been seen is that open and age-appropriate communication beginning in childhood is really valuable because it actually sets the stage for family planning decisions as children get older. So this is our first research study here in blue. So in 2013, a paper was published that really reviewed a variety of other published research studies about communication within families living with chronic illnesses, including NF. So 9 papers focused on the disclosure of genetic information between parent and children under the age of 18. And the key findings are that delayed disclosure to children is common, and it can lead to increased family tensions due to misunderstanding, blame, and secrecy. This paper also found that through a variety of other research studies, early and age-appropriate disclosure has multiple benefits, and you'll see that there are several listed here, but highlighted in our italicized orange is that reproductive decision-making. So even though it may feel like a very long time off before children will be thinking about families, setting the stage for really open conversation and communication around that later on is having open conversation and communication in childhood at an age-appropriate level. And this study also highlighted the fact that children actually want their parents to engage in open and honest discussions about the genetic condition in the family. So if we think about a research study that was released a little bit more recently, there was a survey of almost 260 parents who have children 17 years of age or younger that have NF1. And their key findings were that most parents had disclosed the NF1 diagnosis to their child and had felt it was an overall positive experience. And there were a lot of factors that influenced the disclosure decision. One was a strong correlation between disclosure and the perceived severity of symptoms. And so that makes sense. If somebody is having more symptoms, and that may mean more things that are visible or noticeable or needing medical attention, that it may be a sooner conversation than people who are having different types of symptoms. But most parents in this study reported that they approached disclosure as a process. So it wasn't just a one and done, but it was a process over time and really emphasized the need to be honest and supportive of their child. And I think really importantly, parents highlighted the need for more educational resources and guidance on how to disclose to their children and talk to their children. So another key thing in childhood that I often speak with families about is thinking about genetic testing, not just for what it might be valuable for in the near term in childhood, but actually for the longer term as well. So many reproductive options and technologies that we're going to talk about in a few minutes require having a confirmed genetic test. And sometimes there can be multiple steps that are needed to confirm a genetic finding, and this can take some time. So that's a good thing to do well in advance of considering any type of reproductive decision-making. And also, insurance coverage can be better as a child if they have coverage through a parent or through the state than it is as a young adult, which is often when people are pursuing reproductive choices. So really thinking about having that genetic test for your child as a resource for them down the road when they're thinking about family planning. So if we grow up just a little bit to adolescence, we'll move into a couple things that are a little bit more common for this age group. And the first is puberty and NF. And so again, in the orange are questions that I think come to me in clinic quite a bit from families and individuals, but can NF affect the timing of puberty? And does puberty make symptoms of NF worse? And so what we know is that some children with NF1 can experience early what's called precocious or late what's called delayed puberty. And also we understand that NF tumors can have hormone receptors, which means that they have spaces on their cell surface that can receive hormones. And puberty is a time where there are increased hormones in the body for both males and females. And so it makes sense that people are bringing these questions. And that there may be concern that puberty might make symptoms of NF worse. And so this is one study that's available that looks at this question. It was published in 2014 and looked at 41 children with NF1 that were observed for 20 months, so just a little bit less than 2 years. And this study divided these children into two groups. 26 of the children were in active puberty and 15 were peripubertal, meaning that puberty hadn't really gotten underway yet. And they divided those groups using Tanner staging, which are stages of sexual development, plus hormone levels, plus they looked at tumor volume of plexiform neurofibromas. And what they saw was that the hormonal changes of puberty do not appear to accelerate plexiform tumor growth. They saw no difference in plexiform tumor volume change between the group that was in puberty and the group that wasn't yet in puberty. And they also saw that change in plexiform tumor volume, when it did happen, it didn't seem to correlate with testosterone change in males or estradiol change in females. And so this study indicates that, at least for this group, it did not seem that there were any differences. So something to keep in mind, again, this is only looking at plexiform neurofibromas, but this is one published research study that gets at this question. I think one of the other things that comes up a lot around this time period is birth control and NF. And oftentimes people are asking about whether using hormonal birth control methods can make NF tumors worse. And so this comes up in adolescence because contraception and birth control use is often connected to the onset of fertility during puberty. And it does, again, make sense because we know that there's expression of progesterone receptors in about 75% of neurofibromas. And hormone birth control methods contain progesterone. So if you have neurofibromas that on their cell surface have receptors for progesterone, and then you're taking birth control that contains progesterone, there is a thought that that could upregulate or cause tumors to grow. So if we look at some of the research around this, in 2005, there was a publication looking at 59 females who responded to a survey. And these were people who were currently or previously using hormonal contraception. And the key findings in this study were that the vast majority of people were receiving oral estrogen progesterone or pure progesterone preparations, and they experienced no tumor growth. Significant tumor growth was only reported by 2 people in this study who had received the depot contraceptive with a high dose of synthetic progesterone or progestin. And so let's talk a little bit about different birth control methods. So the chart that's here, you'll see on the left is indicating less effective methods. And then as you go up the chart to most effective methods, this correlates with the right-hand side of the chart, which will give you the percent effectiveness of the different forms of birth control. So some of the things that are important to think about are if you are using, or someone that you know or love is using hormonal contraceptives and they have NF, that choosing a low progesterone or progestin option could be a good idea. And perhaps avoiding shots like Depo-Provera or implantable contraceptions. You can see an implant up here in that top row. It is certainly among the most effective forms of birth control, but may not be something that you want to think about using in the setting of NF or schwannomatosis. I think in having these conversations with many, many people and families over the years, it really is important to balance all of the needs that are in place. And so certainly birth control is usually pursued because of a desire for pregnancy prevention. So it's important to balance being effective enough without introducing additional risk. Some of the other things that are important to think about are ease of use and remembering to use. So things that you need to remember to do every day can sometimes be a little bit easier to forget or skip or miss than something that is a little bit more routinized or mechanized for people. And then certainly different forms of birth control are going to provide different levels of prevention of sexually transmitted infection. And so again, there are often a lot of needs that people are thinking about how to balance and keep in mind as you're considering different birth control methods and talking about them with your provider. I did want to make a quick note here as almost a fact check. I often am looking around on different NF conversation boards and seeing what people are talking about, what the questions are, and what's on people's mind that we can try to provide more information about. And I did see in a couple of places that people had concerns that the copper IUD, which is non-hormonal, and you'll find the IUD up here in that top row of 99% effectiveness, that it wasn't covered by insurance. I just want to say that I think for most people, they do find that this is covered by insurance. And so I just wanted to be sure to maybe if that's a myth that's floating around, sort of bust that myth a little bit, just so that people are aware that there are options around the copper IUD, which is non-hormonal. I think generally what we find is that the risks of birth control don't usually outweigh the benefits of contraceptive use, again, when all of the needs are taken into consideration. And it's really more about making the right choice for you or the person that you're supporting in pursuing birth control methods. And again, there are going to be a lot of factors. So this is definitely a good place to take some information and follow up with your own healthcare provider that can help you think through options and figure out the best choice for you. So if we think a little bit about moving into adulthood, one of the things that I have found comes up around sort of peripherally and sometimes very centrally to the idea of building a family and thinking about reproductive decision making in the setting of NF is socializing, and people that are worried about social and intimate relationships and how they could be affected by visible symptoms of NF. There certainly are a lot of research studies. We're going to look at one or two here that do indicate that people living with NF certainly feel that there is quite a bit of stigma that they experience. And we know that NF can result in varying degrees of visible difference or disfigurement. Young adulthood developmentally is a time where appearance concerns become more prominent. And that actually has to do with changes in the brain that are occurring as we grow up through adolescence and into very young adulthood. So that's a very normal thing. And this is often something that people are thinking about. If we take a look at the research in 2016, a paper was published that surveyed 73 young people with NF1 between the ages of 14 and 24 and 55 parents of young people with NF1. And there were several different measures or tools, different types of questionnaires that were included in the survey. And the key findings were that appearance really is central to young people's experience of NF1. And the more a young person perceives their NF1 to be noticeable, the greater perceived stigma and lower levels of social comfort. And so you can think about this really being a time where people are developing not just friendships and roommate relationships that are going to carry them into adulthood, but also perhaps dating and intimate relationships. And so another study that we can look at that was published in 2013 surveyed 79 women with NF1 and 48 women with NF2, again, including several validated measures or scales within the survey. And their key findings were that the vast majority of people reported appearance concerns. So I think this is letting us know that this is a really important issue for people. Women with NF1 in this study reported significantly more sexual or bodily self-consciousness, and that was correlated with lower self-esteem. where women with NF2 reported significantly more social self-consciousness, which was correlated with lower self-esteem and more loneliness. And this makes sense when we think about how NF1 and NF2 can manifest and the different symptoms people might experience that are related to things that are more visible in the body and things that can interrupt or interfere with communication and socializing. And so these findings make sense. And I think this is just a really important study to help us understand that the vast majority of people that are living with NF1, NF2 schwannomatosis are having experiences that are related to appearance and interaction and relationships, and really developing the relationships that will become the foundation for reproductive decision making. So one of the other things that we circle back to at this point is disclosure. We talked about that in childhood, but it was parent to child disclosure. And what ends up coming up in young adulthood is often disclosure from a person who has NF to a person that is an intimate partner or has another role in their life. So who do I tell that I have NF? When do I tell them? And how much do I share? So again, this can be particularly relevant in the setting of intimate relationships that could lead to marriage and or children. There are often twofold implications. So again, the health concerns for the partner, the person that's living with NF, and also concerns about inheritance for future children. So I want to give a shout out to a great resource on intimacy and NF1 on the UAB website. So the link is here if you want to take a quick screenshot and access that at another point, but it's a really fantastic resource. If we go back into the medical literature in 2013, there was a study published that had interviewed 15 people with NF1, now in the slightly older age range from 18 to 37. And the key findings really were that when and how to tell dating partners or intimate partners is a major concern for people. So this is on people's mind. So if you are on the call and you have a family member, an adult child, a sibling, a friend who's living with NF, this is probably on their mind. So if you haven't had a discussion with them about it, it might be that you want to make space and let them know that you're somebody that can listen and talk with them about how this is going for them and what they're concerned about. This study found large variation in attitudes and practices, and that most people practice what we call partial disclosure, which means they tell some people but not others. And that probably makes sense to a lot of us. The people that were most often told were teachers, employers, dating partners, and close friends. And people were basing this mostly on others need to know and on a positive expectation of how the other person would respond. So often this was going to be having known somebody for a little bit, having a sense of them, and how they were likely to respond to that information. This study, interestingly, found that there was no real difference between people that had more external manifestations of NF1 and those who had less external manifestations. So I think as we begin really thinking about how do you have these conversations and how do you practice open communication with partners, people who might become partners, might become co-parents or spouses, really thinking about how to lay a good foundation for that going into the relationship and in the early stages of the relationship. Because as you'll see, there may be some decisions that'll be really important to talk openly about as you think about pursuing a pregnancy. And so let's talk a little bit about inheritance of NF. So often in clinic, I will hear the question, if I have kids, will they have NF? And I just wanted to unpack this with us for a little bit. I think there are actually two questions I have found are packaged up into one question here. So the first question that's in this question is, if I have kids, will they have the gene variant for NF that I or my partner has? So let's talk a little bit about that. We know that that genes for NF1, NF2, schwannomatosis are all what are called dominant. And what that means is that, well, each of us has two copies of each of those genes. Only one of those needs to have a variant in order for people to potentially have symptoms. And so in this cartoon here, the unaffected parent happens to be a mother and the affected parent happens to be portrayed as a father. And then these sort of stick figures here are chromosomes, and the genes are in these white boxes. So say this is a gene for NF. So these are two unaffected copies from one parent. And then the parent that has NF has one unaffected copy and one affected copy, meaning this has a gene variant on it, and that gene isn't really working in the same way that we would normally think, and that's why symptoms are occurring. And so every time people have a child, they're going to pass on one or the other. So that's why we think about things being sort of having a 50-50 chance if you have an affected parent. So in NF1 and NF2, about half of people inherited it from a parent, and the other half of people that have this diagnosis are the first person in their family to have it. This is called de novo, or meaning new. It's a little different in schwannomatosis. About 15 to 25% of people inherited it from a parent. And so a larger number of people are the first person in their family to have it. Importantly, once you have any one of these NF gene variants, you have a 50% chance of passing it on in each pregnancy. So that's that 50-50 that we talked about previously. And that's true for NF1, NF2, and schwannomatosis. I think a question that often comes up is around mosaicism. So let's talk a little bit about what that is. What that means is that only some cells in the body have the gene variant and the other cells do not. And so how that happens, here you can see in the cartoon that there's a sperm depicted and an egg cell. And as they come together, it's called a zygote. Mitosis means that the cell starts to divide and divide and divide. And at some point in the process, there is a change in a gene, in an NF gene that didn't exist earlier on. So it didn't come from the sperm and it didn't come from the egg. It's brand new. But it doesn't happen in the very first cell, it only happens later on. So then as the cells continue to divide, only some of them have that gene change. And so here is a depiction of a baby, a fetus, a pregnancy. And you can see a portion of the cells have that variant, but the rest do not. And so then as a person grows and develops, they may have symptoms in parts of their body, but not in their whole body. The gene change may exist in parts of their body and not in their whole body. So what this can mean is that as we think about this idea of something being 50-50, so if you have a mosaic form of NF or schwannomatosis, do you have the same chance of passing it on to a child? So here in this instance is another depiction of the early embryo with numerous cells and only one of them that has the gene variant. And as those cells implant and grow into an embryo, fetus, a baby, and into a person after birth, that this person only has the gene variant in a certain part of their body. And so sometimes when you do a blood test for the gene change, you don't see it. The blood test returns normal and you don't see any type of gene change. But if you actually take a cell from a cafe au lait macule or from a neurofibroma and you look there, you can see the variant. And so then we start thinking about, well, does this mean this person has the same likelihood of having an affected child as if they had NF1 or schwannomatosis in every cell of their body? And here that gets a little bit tricky to figure out. So the likelihood of passing NF to a pregnancy can range in cases of mosaicism. So it could be as high as 50-50, but it could be lower than that. And it's difficult to know exactly what that number is going to be for any particular person. In this graphic here on the lower right, you can see that the affected cells are here in the leg and the hip area. That is pretty close to the part of the body that produces egg, produces sperm. And so is it more likely that that variant could be in egg and sperm for this person than someone who might have a mosaic form, but it's perhaps in their shoulder or their upper arm? And, I don't think we always know the answer to that question. And so generally you might hear that the chance is probably less than 50%, but that it's hard to put a specific number on it. One thing that's become available in recent years is sperm analysis for males with mosaic NF that can help to estimate the percentage of cells that may be affected with the NF1 variant, and therefore what the chance is of potentially passing that on. So sometimes people say, well, how do I know if my NF is mosaic? So I think the very first important thing is that it's only possible to have a mosaic form if you're the first person in your family. So if you have a parent with NF or schwannomatosis, then you won't have a mosaic form because it would have come from the egg or the sperm, and it would be in every cell of your body. Sometimes it becomes more likely you have a mosaic form if your symptoms are limited to only one part or one side of the body. If you have a blood test or a saliva test, a genetic test, and the variant is seen in less than half of the cells, that could be an indication that it's mosaic. And again, if the variant is not found in blood or saliva, but then when doing genetic testing on a tumor or a cafe au lait macule, the variant is present. These are all things that mean it could be mosaic. And so again, something to discuss with your healthcare provider if you have questions about that. So if we go back to the question that we were talking about, if I have kids, will they have NF? I think the second question embedded in this is, if I have kids, will they have symptoms of NF, and which ones? And this is a little bit different than asking, will they inherit the gene variant? And we'll see why in a minute. There are a couple of things that we know happen in the setting of NF and schwannomatosis. One is called penetrance. And what this means is the percentage of people who have the gene variant and also have symptoms. So that's important because some of these gene variants, if you have it, you will definitely have symptoms. And other of gene variants in NF, if you have it, you won't necessarily ever develop symptoms. And so again, a child could inherit the gene variant, but not maybe ever develop symptoms. And so that's an important distinction. Another thing to think about in the setting of this question is what we call expressivity. This means how much symptoms will vary between people who have the same gene variant. And so if you're in a family where more than one person is affected with NF or schwannomatosis, you might notice that people have different symptoms from each other. And we see that regularly, that it can be different between people in the same family who we know have the exact same change in the gene because they're related to each other. And so we know the expressivity is variable between family members in the setting of NF. We also talk sometimes about what's called genotype-phenotype correlation. That means how much can you know? If you know the exact variant in the gene, can you predict which symptoms will occur? And this is something that is the case in some situations with some gene variants in NF, and other gene variants can't tell us as much. And so if we think about each of these things with each of the three conditions that we're talking about today, let's start with penetrance. In NF1 and NF2, penetrance is 100% or complete. So we know if a child inherits the gene change, they will develop symptoms of some type. Schwannomatosis, it's different. So penetrance of schwannomatosis is less than 100%. We know that there are large families where some people, a variety of people carry the gene variant, and only some of them ever develop symptoms and others don't, even though they have the gene variant. And so that's an important thing that people want to think about sometimes. If we think about expressivity, NF1 and schwannomatosis can be variable within families and between families, whereas NF2 is a little bit more consistent within families, but variable between families. So two different families can have different symptoms, but we often see similar types of symptoms within the same family. And the last category of genotype-phenotype correlation, it's actually pretty low in the setting of NF1. Only about 10% of gene variants will actually be able to tell you something about likely symptoms. In NF2, it's a little bit higher. So it's a little bit more likely in NF2 that a gene variant can help predict symptoms. And in schwannomatosis at this point, there really isn't enough information to have any genotype-phenotype correlation that's well accepted right now. So just a last note about inheriting NF gene variants. This is another thing that I sometimes see on discussion boards, and people will ask in clinic. But children can only inherit the gene variant that the parent has. So if somebody has NF1, they are not at risk of having a child who inherits NF2 from them. It can only inherit the gene variant that the parent has. And so if we look at these three conditions we're talking about and the genes that cause them, these are the genes that can have variants that cause symptoms. You can see there's several genes for schwannomatosis and only one gene for NF2 and one gene for NF1. Importantly, for people that have LZTR1 as the cause of their schwannomatosis, we've actually learned in recent years that if a pregnancy inherits an LZTR1 variant from both the sperm and the egg, the fetus or the baby could develop a completely different syndrome than schwannomatosis. It's called Noonan syndrome. It's really different and has very different symptoms. And so if you have an LZTR1 variant, you may want to consider testing for your reproductive partner in advance of a pregnancy, even if they don't know that they have any symptoms at all of schwannomatosis, because if you remember, this is one that is not fully penetrant. So sometimes people have a variant, but they don't have any symptoms. And because there is an increased chance of having two of these variants causing a different condition, that's something that's important to think about. So if we move into thinking about pregnancy directly, there are often questions around fertility and NF. And broadly, NF itself doesn't seem to impair fertility. So having NF, NF2, NF1, schwannomatosis doesn't seem to impair fertility. But we want to think a little bit about treatments for NF. So this is a question that comes up a lot. Can treatments used for NF symptoms affect my fertility? So we do know that some drugs and medications are known to reduce fertility. So examples, these are drugs and medications that can be used in the setting of NF. mTOR inhibitors, like Afinitor, which is everolimus, can reduce sperm production and decrease sperm motility. We know that Avastin or bevacizumab can cause ovarian failure. In terms of Koselugo or selumetinib, there really isn't any data yet about any effect on human fertility. So what that means is that it's not known to be safe and it's not known to be unsafe. At this point, there's no data on this. So these are always important questions to be thinking about and asking to your care providers that are prescribing medications for your NF symptoms or your loved one's NF symptoms. And beyond medications, it's important to think about a few other things as well. So radiation therapy, which is sometimes used in the setting of NF tumors, can impact fertility. It depends on the area being treated, on the dose, and on the number of treatments. But what we can see for males is potentially reduced sperm production that can be temporary or permanent. And for females, there can be damage to ovaries, uterus, and pituitary gland, again, depending on the area being treated, the dose, and the number of treatments. So we always encourage people to discuss fertility with a fertility specialist before starting treatment, or if you've been utilizing treatment or your child has been utilizing treatment, to have those conversations now and be thinking about fertility preservation techniques, or times in life where it might be important to think about not being on medication for a bit, if reproduction and reproductive options are of high importance. So if we think about fertility preservation, often we're talking about semen cryopreservation. This can be used in conjunction with IVF, ICSI, or other methods of reproductive endocrinology. There really are not thought to be any higher rate of birth defects using cryopreserved or frozen sperm than using fresh sperm for a pregnancy. And costs range from $300 to about $1,000. This doesn't include annual storage fees, which might be around $500 a year. These are just broad estimates to give us an idea. But you'll see that it's really different for oocyte or egg cryopreservation. This can be used in conjunction with IVF only. And we actually do see that the transfer rate is lower than with fresh oocytes. So using frozen eggs, the transfer rate is about 30%, where with fresh eggs, it's about 50%. So similar to semen cryopreservation, we don't really think of higher rates of birth defects than when using fresh oocytes, but the costs are really different than semen cryopreservation. So costs can range, again, these are just rough estimates, from $5,000 to $8,000. This, again, does not include Another cost in the setting of oocyte cryopreservation, this is fertility medication that can be $6,000 to $7,000 for those medications. And importantly, people do find that this is much less often covered by insurance. So important to be thinking about in the setting of choosing different treatments for NF and thinking about family planning. I do want to underscore, maybe you can tell that because this popped up in a very big box with a red outline, but you are not able, none of us are able to do genetic testing using a sperm or an egg alone. Genetic testing can only be done using an embryo or a fertilized egg that has divided several times because it's done by removing one cell from the embryo and testing that cell. And it has to be at the time where the embryo has enough cells that losing one is fine. And so it can't be done on a single sperm or egg alone. So when we think about prenatal diagnosis and NF, how can I learn if a pregnancy has inherited the gene variant? It's really important to know the exact gene variant in the family already. So this is when we were talking earlier about potentially undergoing genetic testing in childhood to be sure to have that information in adulthood when people might want to use it in the setting of a pregnancy. Prenatal diagnosis typically happens these days between two main methods, chorionic villus sampling or CVS and amniocentesis, or what people sometimes call amnio. And again, it's important to keep in mind that there's variable expressivity and incomplete penetrance of some types of NF. So if someone achieves a pregnancy and undergoes prenatal diagnosis and learns that the pregnancy has inherited the variant, it's important to remember that that's not going to be able to tell you what symptoms that pregnancy, if it did continue and a child was born, what symptoms would that child have? Would they ever have symptoms in the setting of schwannomatosis, for instance? So the testing that can be done during pregnancy can tell you if the gene variant is there or not, but is not able to tell you anything about the development of future symptoms. So it's important to balance the desire for having this information as well with the risks of the procedure. So both CVS and amnio are invasive tests. They both come with a small risk of miscarriage secondary to the procedure. Some people want this information for planning purposes and want to be ready to welcome a child into the family who may be affected with NF1, NF2, schwannomatosis, and some people might pursue pregnancy termination if the fetus is affected. And so really thinking about what would I do with this information? Is it important for me to have it now and important enough to take that small risk of miscarriage? Or is this information that I'm okay waiting until after a child is born to have? I do want to say in the setting of thinking about prenatal testing for people who might want to use that information to consider whether they would continue a pregnancy or not, that abortion services, of course, in the last several years have become increasingly limited. And so depending on where people are living, it could be harder to access abortion services as well. So that's something that families are often wanting to ask questions about as well as they're considering their own options. If we think about what each of these procedures involves, chorionic villus sampling or CVS is typically performed in the first trimester around the end, so 10 to 12 weeks of pregnancy. And it can be done either transcervically, that means that there is a flexible tube that's inserted through the cervix to take a small sample of the placenta. And so you can kind of see that flexible tube being inserted here and reaching the placenta here, far, far away from the developing fetus. Transabdominal CVS will actually enter through the abdomen with a needle to take a portion of the placenta from here. The placenta is made by the developing fetus, and so the DNA is the same. And so then what happens is the sample is taken from the placenta and then sent to the lab, and chromosomes or DNA can be extracted from that sample, and then testing for NF can happen at that time. Amniocentesis is performed a little bit later, early second trimester, 14 to 16 weeks of pregnancy. It is always transabdominal, so going across the abdomen with a needle to take a small amount of the fluid that surrounds the fetus. And in that fluid, these look a little, I think these look a little bit like SpaghettiOs. That probably tells my age. but these are actually meant to be cells. They are skin cells that are sloughed off from the fetus during normal development during pregnancy, and those cells have DNA. And so those cells are collected, sent to the lab, and again, chromosomes can be extracted and DNA can be tested. So importantly, pre-implantation genetic testing is available for NF and all types of NF. And what this means is that it's a combination of using in vitro fertilization, where a woman takes hormones and ovulates many eggs in a single month rather than only one. They are removed and sperm sample is taken and they are combined in a lab to create multiple embryos. And then at about day 3 of the embryo growing and dividing cells and growing again, one cell is taken and tested for the gene variant. And all of the embryos that are negative could be available for transfer, and the ones that are positive are typically not transferred. This is a microscope photograph of extraction of a cell for a PGT. So if we look at some research about outcomes of PGT for NF1, we can see, we'll look at 2 different studies and compare them, one from 2015 and one from 2023. So one was a US center and one was a Dutch center, but you can see that diagnosis was possible for about 80% of the embryos that were created, and you can see the outcomes in terms of live births. So again, this is implantation only of unaffected embryos. And there was about a 21% live birth rate in the US study and about a 24% live birth or ongoing pregnancy rate. So I talk about this with individuals and families around PGT being, for some people, a good option as a way to prevent passing on a gene variant in the family. But important to understand that going through the entire process of PGT doesn't mean that there will be a pregnancy that is carried to term and a live birth. So you can see the rates are about 21, 24%. Things that can complicate PGT: certainly not having the resources, monetary, emotional, psychological. It is a long and sometimes very expensive road. Insurance covers some portions sometimes and not other portions other times. Sometimes what complicates PGT is not being able to easily detect the known genetic variant of the parent that's affected. This again speaks to working out some of the genetic testing and having a confirmed result well in advance of wanting to do family planning. Sometimes there are maternal health concerns that can complicate PGT. Sometimes these are related to NF and sometimes they're not. There certainly can be difficult decisions. Even if a pregnancy is achieved, there is a much higher rate for multiple pregnancy, meaning having 2 embryos implant or 3. Sometimes there is need for fetal reduction, meaning that too many embryos have implanted, and there needs to be a reduction. And also people need to make choice about the status of the remaining embryos, so the embryos that tested positive. And for some people, those are easy decisions, and for some people, they are not, and they can complicate the process of using PGT. We also know that there have been, in the past few years, changing reproductive laws, even around IVF. This is a picture from about a year ago, at state levels, at federal levels, and so really having an understanding of what is happening in our socio-political culture as well that could impact the technologies that are needed and the procedures needed for PGT. So we talked about a lot. This is my way of trying to sum it up in one table for you and think about different things that families often wonder about, talk about, people are considering. Is it important to me, across the top of our chart here, that my child is biologically related to me? Is it important that I have a natural conception? Is it important for me to think about the financial cost? Is genetic testing needed? So is it important for me to have my genetic test result in order to utilize any of these options here? And so, again, this is sort of a table format of a lot of sometimes ongoing and in-depth conversations and counseling and support for people that are considering family planning in the setting of NF. So maybe we'll close with thinking about pregnancy complications and NF. Sometimes people will ask if NF causes pregnancy complications. Will I be considered high risk by my OB? Will I need special management? And can pregnancy make my symptoms worse? So pregnancy complications can occur for the fetus and also for the pregnant person if they have NF. But that people with NF who are pregnant don't necessarily need special management and may not be considered high risk. And so this is really dependent on what types of symptoms you have. Some people with NF have higher blood pressure and they might be considered high risk. Other people have tumors in certain locations that are related to birthing that might make them higher risk. So there are very specific things to talk about with your care provider. If we look back at a study from 1996 that surveyed 105 women with NF1 who had 247 pregnancies, about 75% had live births. There were 46 miscarriages and 21 terminations in this group. And close to half reported progression of cutaneous neurofibromas during pregnancy. So you'll see that about 60% reported growth of new neurofibromas and about 52% noted enlargement of existing neurofibromas. So I think, it can feel like, oh, well, that means pregnancy definitely causes cutaneous neurofibromas to grow and develop. But I think an important component here is that cutaneous tumors continue to develop into adulthood and as people get older, even when people aren't pregnant. And so it's sometimes very difficult to determine whether it was even related to the pregnancy and whether it might have happened anyway. So this is, I think, is always an ongoing conversation that people have, and is an important one to have with your care providers. There was also a study in 2013 that looked back over about 20 years and about 1,550 pregnancies to women with NF1 looking at pregnancy complications. And there were some things that were seen more often than in the general population, and they're listed here. And importantly, there were some pregnancy complications that were not seen more often than the general population. And so I think oftentimes having these conversations with providers when you're thinking about pregnancy is really important to share the things you're worried about, because it could be that there's good evidence that those are not things that are more likely. So again, just a plug to talk to your care team. Again, we circle back to the question about whether treatments used for NF symptoms can be harmful to a developing fetus. And so we do know that some drugs and medications used to treat NF symptoms can cause birth defects that are totally separate from NF, but important to consider. So some medications used for NF tumors, for pain, for ADHD, for epilepsy, which can all be part of NF, can cause birth defects. So if you're taking medications for any of these things, it's really important to talk about with your maternal health provider. As well, some evaluation techniques should be avoided during pregnancy if possible. So gadolinium, which is a contrast media that's often used with MRI, should be avoided. But important that MRI itself is safe during pregnancy. It's the gadolinium that should be avoided. PET scan should be avoided when possible during pregnancy because there's potential for fetal loss, birth defects, growth differences, and high-dose radiation, such as CT or an X-ray of the abdomen or pelvis, should be avoided if possible during pregnancy. Sometimes people ask if they need to have a cesarean section. Not automatically. So it really depends on the individual case. This is a really important thing to talk about with your doctor so they can talk specifically about what's happening for you. We already talked about just a moment ago, high blood pressure and obstructive tumors in the birth canal. So those might be reasons to think about a cesarean. But again, this really needs to be a conversation between you and your care provider, because there are risks associated with C-section as well that are important to be thinking about. And one other point that I think is something we talk about a lot with people, is that anesthesiologists are sometimes uncomfortable using epidural for pregnant people with NF. And so I think it's important to be aware of this and to talk with your anesthesiologist in advance. They might recommend an MRI before getting pregnant in order to have an epidural. And in talking with a lot of NF neurologists, without any neurological symptoms, this really isn't necessary. So if you're hearing this from an anesthesiologist or a care provider around pregnancy, be sure to check in with your NF doctor. And we'll just end up with after birth, breastfeeding and NF, and a question that often comes up about treatments being used for NF symptoms. Can they be harmful to a baby who's breastfeeding? Some medications are known to be unsafe. So certain pain medications, epilepsy medications or anticonvulsants, and chemotherapeutic agents are known to be unsafe when breastfeeding. Then there are a variety of other medications that can be used in the setting of NF that are not known to be safe or unsafe. Again, this is the ones with no data. So Koselugo or selumetinib and Avastin or bevacizumab. There's not enough data to know if they're safe or not. And so these are, again, really important conversations to be having as you're thinking about family planning. Last slide is a plug for genetic counselors that we are here to provide factual information in an understandable manner around a lot of aspects related to family planning, helping you facilitate decision-making that is aligned with your own values and your own motivations, and certainly providing emotional and psychological support along the way. So if you're looking for a genetic counselor near you, you can find a list at nsgc.org. And if you're looking for me, this is where you can find me. So I'm happy to answer questions. I'm not sure how much time we have, and if we run out of time, I'm also happy to, if Kate would like to collect some questions, and I can create a little Q&A that can be shared with everyone that attended.
Yeah, that's perfect. Thank you so much, Amanda. We are almost at time, but I think there's so much interest in this that if it's okay with you, there's just a couple of questions I thought I'd have you respond to.
Sure.
Thank you. So there were a lot of questions around the idea of the cutaneous neurofibromas getting worse during pregnancy. And I know that you covered this, but I think it might be helpful. One, there's questions around if we were to use fertility treatments and a surrogacy. So then the woman affected with NF1 is not actually pregnant. Do we know if it's the medications that induce ovulation? And then just generally speaking, maybe a quick review of, that we think maybe there's an increase in cutaneous neurofibromas, but I know you were talking about how it's not really clear that the correlation is there.
Right. So if you yourself are pregnant and are concerned about growth of cutaneous neurofibromas, I think there are definitely stories of many people who would say, yes, I have had growth. And that research study showed us that half or a little more than half of people said I had new cutaneous neurofibromas, or the ones I already had got a little bit bigger. It is really difficult to know if that's because of the pregnancy or if that would have happened at that point in life anyway, because we know that that is what continues to happen for cutaneous neurofibromas. I think what that also tells us is that half of people were pregnant and had no growth of their existing neurofibromas, and 40% of people in that study didn't have any new cutaneous neurofibromas. So when it comes, you can look at a big population of people and create fancy statistics and numbers, but when it really comes down to it, you're sort of asking, well, what's going to happen for me? And it's really hard to know if you're going to be in that 40% or in that 60%. And so I think that's one of those questions that is a little bit more nuanced around what is most important to me about having a family and being pregnant. And is this worth the risk for me? And are there other options I would rather consider? And so those are not easy blink of the eye questions to answer for yourself. And sometimes it's really helpful to have those conversations over time with people that have a lot of information about it.
Yeah, thank you so much, Amanda. This was fantastic. There was so much engagement in the chat and in the Q&A, and I really appreciate you taking the time. And for those of you, if you can stick around a minute, I just have a few housekeeping things. I want to make sure to get some information to everybody. So just going to quickly share my screen. And like Amanda said, not only did she say that she would make herself available, I'm also going to make sure you have my contact information as well. So anyone can reach out to me, and I know how to get a hold of Amanda if we need to. So just quickly, we do have these new resources that are available to you. The ctf.org/genetics, that link does work. And you can go there to find all of these new resources that we've just released. They're available in English and Spanish right now. Also a reminder that the NF Summit is happening in June in Washington, D.C. This is a fantastic opportunity to gather with other people impacted by NF, to learn and to connect, and to just feel that sense of community. For more information, you can go to NF Summit. Well, you could email us at nfsummit at ctf.org, but nfsummit.org will take you to the website. The next webinar we're hosting is on May 22nd. This is in honor of NF2 related Schwannomatosis Awareness Day on May 22nd. And we'll be talking about the way that CTF is funding and driving research specifically in that space. So you'll hear from our CEO, Dr. Bacher, as well as our CSO from our CTF Europe group, Dr. Nievo. So for more information on that, reach out to me. And then there should be a register link in your chat right now as well, if you want to register for that webinar. Last thing is, if you are not getting it yet, please sign up for our newsletter. That's how you're going to stay in touch and hear about all these things that we're putting together, these opportunities for you. And then here is my email. It's kkeltz@ctf.org, and I'm available at that address anytime to answer questions about this webinar or anything else about your NF journey. So thank you again to Amanda and to everyone for joining us here today. I hope you have a wonderful rest of your day. Thank you, everyone.